All right, hey guys, we are going to go ahead and discuss blood administration and transfusion. We have touched on this in lab when we were priming our tubing, but just to reiterate all of the important aspects from this portion of IV therapy, we're going to go ahead and just go over them one by one. So a blood transfusion. The nursing focus is on the safe procedure for administering blood products and monitoring for signs and symptoms of transfusion reaction. So we're going to be giving blood to patients with a low blood count, obviously. They can have deficiencies of red blood cells. They're usually symptomatic if we are giving them blood. We know that our red blood cells are going to carry they're going to carry the oxygen throughout. Our hemoglobin is going to carry that oxygen throughout our body. So oftentimes if our patients are very anemic, they're going to be short of breath, they're going to be pale, they're going to have some negative implications as related to those low counts. If our patient has low platelets, then they're going to have signs and symptoms of bleeding. So we will be giving, we will need to know their lab values prior to giving blood, and we'll need to anticipate, our blood is made for our body. So when we receive the blood that comes from another individual's body, there's a lot of fear surrounding that with your patients. And there's also a risk that your body can not respond well to that blood. So that's some of the stuff that we're going to discuss. So when we give blood administration, our objectives are to restore and maintain blood volume, to restore and maintain coagulation factors, which would be your platelets, to improve the oxygen carrying capacity of the blood, and to treat those blood deficiencies. So when we are giving blood, we're going to do a match because the donor has to be compatible with the recipient. So our patients who have A blood, they can get A blood or they can get O blood. Patients with B blood can get B blood or O blood. And then our patients who are AB, have the AB antigen, they can get AB, I can't get it right. They can have AB blood, they can have A blood, B blood, or O blood. The universal donor is your patients with O negative blood. So a person with O negative blood can give to any of, whether your patient is A negative, A positive, AB negative, AB positive, your universal donor is O negative. And then your universal recipient is AB positive. So they can receive any of those blood products. So autologous donation is the donation of a patient's own blood before a scheduled procedure. So some patients are going to have reasons why they do not want to receive a blood transfusion. It could be fear. It can be related to the fact that they just religiously are against it, multiple reasons. So if they have scheduled surgery, your body naturally builds, if they are just lose a little bit of blood, your body naturally reproduces those things. So a little bit ahead of their surgery, they can donate their own blood. It can be stored. They will have the opportunity their body will build back up a little bit of that blood that they have donated, and they can receive their own blood in a blood transfusion during surgery. When we are talking about compatibility, that is when we match the blood from two people and from two types of antigen systems. So we're going to determine those. A while ago when I just told you if they're A, then they can receive A blood or O blood. We have to first determine what is their blood type. Are they A, B, or O? And then their RH factor. Are they negative or positive? And those are all of the things that we must know in order to administer a patient blood. If we have no idea what their blood type is, then we would have to give them, and it's an emergency situation, we would have to give them O negative blood. When we cross-match, we are testing the donor's blood and the recipient's blood for compatibility. And then if we have a designated donor, we have a compatible donor who has been selected by the recipient. It does not decrease the risk of contrasting infections. So what is going to happen is sometimes we can say this blood is, when you go to donate, you can say, I am the designated donor for so-and-so. It's still going to go through that battery of testing, but some people are just unwilling to receive the blood of a stranger. And we blood centers try to make this as, they have to consent to receiving the blood. So they try to do what they can, in regards to that. Transfusion is when suction is provided by a drainage system, blood is collected in a sterile bag, and the blood is administered back to the patient. So that happens if a patient is if they don't pre-donate, that's autologous, but if they are losing blood during a procedure and we can collect it in a sterile bag, we will administer that back to them. That takes place in a surgical setting. So RH factor, everybody has factors. So if one has the factor, then it's going to be positive. And if one doesn't have the factor, then the blood is going to be negative. And this is the RH factor. The presence or absence of RH antigens on the surface of red blood cells determine if the RH is positive or negative. So these antigens, you either have them or you don't. So that's what makes you positive or negative, and that's your RH factor. Excuse me. So red blood cells, we know, are a blood product that's used to replace erythrocytes lost as a result of trauma or surgery. We're also going to give these to patients with bone marrow suppression. They're going to be used to treat decreases in hemoglobin and hematocrit. So your patient's HNH is low, we would expect them to receive red blood cells. If they have had blood loss and we need to improve that oxygen carrying capacity in symptomatic anemia. So not everybody so you need to know your norms for HNHs. So someone can be anemic but not need blood. So that's something to keep in mind too. Some people live with a low HNH, but they're not symptomatic and they're not short of breath, and it's not having a negative implication on their life. So we are likely not going to just give those people blood transfusions. They're usually designated for people who are symptomatic. So for packed red blood cells, all of the blood that you give is going to have a label on it. This label is going to contain the type of blood, like we talked about. Is it O positive? Is it O negative? Is it AB positive, etc. It's going to have a unit number. It's going to have an expiration date, and it's going to tell you how much blood is in that container. Leukocytes are going to be given, leukocyte reduced red blood cells are going to be given to prevent febrile non-hemolytic transfusion reactions. When a patient is getting a lot of transfusions or they have a diagnosis such as leukemia or hemophilia, we are going to want to give them red blood cells with lesser white blood cells because we don't want them to have a reaction to these multiple blood products that we're getting. If they have less, if that leukocyte count is reduced in those red blood cells, then it decreases their risk for that febrile transfusion reaction. Further transfusion definitions. Wow, you can tell it's been a long day. I'm sorry. So when we talk about a patient having, when we talk about them having a therapeutic effect, actually, we'll come back to that. I don't want to talk about irradiated blood products right now. Let's talk further here. So when you get a transfusion order, it will say to transfuse RBCs, WBCs, plasma or platelets, and it will tell you, it might be whole blood, it might just be platelets, or it might be RBCs, but you'll need to know what that order is because you'll need to send that order to the blood bank. So when we're giving whole blood, the primary purpose, so we can give whole blood, which has all of those things in it, or we can give those individual components. When we give whole blood, the purpose is to restore volume because they have lost blood containing all of these. So we know that platelets If we're just giving platelets, we would be giving them to patients with low platelet counts, which means that they are going to have some problems with clotting. They're thrombocytopenic, and they're either bleeding actively or they're going to be having a procedure where we are expecting them to bleed. So we need for their platelet count to be normal so that the body can go through those normal mechanisms of action in regards to clotting. So, for example, thrombocytopenia, leukemia, those are examples that those are given. Platelets are not given over a long period of time like blood is. They are given via transfusion over about 15 minutes, and a filter must be used. Okay, and these are examples of filters. And this is a blood transfusion set with the PAL filter. So this is the type of set that you would use. I know y'all saw the Y tubing that we gave for regular whole blood. This is what we would use for platelet administration. And platelets do look different than blood. They're not red. So this is what platelets look like. So fresh frozen plasma is a blood product administered to increase the level of clotting factors in a patient with a clotting deficiency. We are going to provide replacement of the coagulation factors 5 and 11. It must be thawed prior to infusion. And we are going to monitor the patient's PT, PTT, their blood pressure, and their heart rate. Examples for patients who would need fresh frozen plasma would be that multiple of their coagulation factors are deficient, secondary to liver disease, patients who are in DIC, or patients who have thrombocytopenia. So fresh frozen plasma looks very similar to platelets. It's not red like regular blood. And this is a good way to see the way that it's spun down and separated. This is the plasma. These are your white blood cells and platelets, and this is your red blood cells. This is a really good picture so you kind of know what your, we just think blood is red, but we don't think about those individual components. So if our patient is low in platelets, they don't necessarily need all of this whole blood. They just need those platelets. And then in regards to the fresh frozen plasma, they just need what they're lacking in clotting factors. So here to your nursing interventions and concerns regarding transfusion. American Red Cross procedures to detect HIV have dramatically reduced the incidence of its transmission by means of blood products. So that used to be a really, really huge problem. You get in this situation, years ago, they didn't screen blood the way that they do now. So it's like, I need blood to save my life, but I may contract HIV or I may contract Hep C in the process. And, so that's where a lot of that fear comes from for people who don't want to receive blood. But procedures have dramatically reduced that incidence. Plasma expanders such as dextran and albumin, we can use those for patients who refuse blood transfusions because of personal or religious beliefs. So they can essentially bring about similar results, albeit they're not blood. They can still increase the volume of it within your patient's intravascular spaces, and maybe improve some of those reasons why your patient needs blood, some of those symptomatic things that are going on. So if your patient refuses blood, there are some alternatives out there. So Jehovah's Witnesses believe that the Bible prohibits the transfusion of blood, even in the case of emergencies. It is a very big deal to them, and it is not to be questioned. We can educate, but at the end of the day, it is their decision if they want to receive blood or not. And they usually have a plan of care specific to them that they have discussed, that they keep in their wallet, and they make their wishes known. Most and of course, every case is individual, but most Jehovah's Witnesses believe that using their own blood is okay, so they will donate prior to surgery. And a lot of them are okay with using those blood substitutes, such as that dextran and albumin, to prevent shock when their volume is low. The reasoning behind their beliefs is that blood represents life. They feel like it's sacred. It's reserved only for one special use. When a Christian abstains from blood, they are in effect expressing faith that only the shed blood of Jesus can truly redeem them and save them. So this is a deeper thing than just being afraid of receiving blood. They, at the root of their faith, they do not want to receive blood. Blood must not be eaten or transfused, even in the case of medical emergencies. Blood leaving the body of a human or animal must be disposed of as part of their current therapy. And a baptized Jehovah's Witness who unrepentantly accepts a blood transfusion is deemed to have disassociated himself from the religion by abandoning the doctrines, and is subsequently subject to an organized shunning by other members of their community. So it is so much bigger than just, I don't want to receive blood. You know, it's a very big deal. It's a very personal decision that should be respected. And it's something that you need to be aware of as a healthcare professional, that, you know, we always talk about cultural considerations, and this is a very, very big cultural consideration. So again, these are just other things, other outside of Jehovah's Witnesses. Christian Science teaches a reliance of God for healing rather than on medicine or surgery. It would be unusual, therefore, for Christian Scientists to be patients in ordinary hospitals. They have no special objection to blood transfusions like Jehovah's Witnesses do, but they're just different. They have different desires in regards to relying on spiritual means for healing, not necessarily those scientific things like receiving blood and those type of interventions. So they will not be shunned, but oftentimes they will be against blood as well. Then you'll have just your people who know someone who contracted a disease or who had a really bad blood transfusion reaction, and they're going to have a lot of fear associated with receiving blood. Transfusion complications could include the transmission of diseases like hepatitis B, C, HIV, or sepsis if that blood is contaminated. So we have several different types of transfusion reactions. So the first is a febrile complication, a febrile reaction. This is the most common transfusion reaction. And the risk increases with each unit of blood administered to the patient. So when we talked earlier about patients who have leukemia or who are getting multiple transfusions, the more transfusion you get, the likelihood of these febrile reactions increase. It can occur during or after transfusion, and the signs and symptoms are a fever greater than 101 and a sudden onset of chills. If they receive this, then a future febrile reaction can be prevented by administering leukocyte-depleted blood. And also, a lot of physicians will order Tylenol and Benadryl to be administered prior to blood administration. You can have a urticaria reaction, which is something like hives. Urticaria, excuse me, I struggle with that word, urticaria. It's caused by the antigens in the plasma, and it is treated with Benadryl. So again, these reactions are not necessarily life-threatening. Usually we treat them with medications orally to either prevent or combat these types of transfusion reactions. An acute hemolytic reaction is a very big deal. It is caused by the transfusion of incompatible blood, and it results in hemolysis of the red blood cells. So the red blood cells actually kind of explode, for lack of better terms. They lyse. It is the most deadly and the most rare of reactions. It's also why we must cross-match. We must check, double check, have a second nurse check But when this transfusion reaction occurs, your patient will have back pain, chest pain, chills, fever, shortness of breath, nausea, vomiting. And then later on, if it's not caught right away, they could have hypotension, shock, and a decreased level of consciousness. This is a problem. So with this type of reaction, we'll talk about that in a little bit. You always, if they start exhibiting any of these signs, you absolutely stop that transfusion immediately. And then there are anaphylactic reactions. They're more common in patients who have received many transfusions, and they can cause respiratory or cardiovascular collapse, also life-threatening. They may present with shortness of breath, dyspnea, hypotension, and a decreased level of consciousness as well. Lastly, we have circulatory overload. It's caused by rapid transfusion in a short period. It's most common in older patients and patients who already have renal or cardiovascular impairment, the same patients that are at risk when we are just giving intravenous fluids for being in circulatory overload. In regards to what we're looking for, remember we're talking about their heart-like symptoms. You know, their heart cannot, their circulatory system cannot support the volume that is within those vessels. So they are going to have things like respiratory distress, jugular vein distension, their sputum will be frothy, they'll have crackles, and their lungs will sound wet, their heart rate will increase. And we're usually going to give diuretics to these patients so that we can kind of get some of that overload off of them. So in regards to transfusions, each facility is going to have different policies that they are going to review over and over, and you'll have to acknowledge. So they're all a little bit different. Every policy that I have seen, every place I have worked has required 2 nurses to look at the blood and to verify the blood before beginning the blood. Some places require RNs to hang the blood. Some places, don't require it to be an RN. You must know your facility policy in regards to if you were able to hang that blood or not. Sometimes you can't hang it, but you can monitor it as an LPN. So all of those things are things that you just have to know your role. And then facility policies will dictate how often you're doing vital signs on these patients. They'll also dictate how long you have to stay with the patient, all of those things. So your job is to monitor their lung sounds and vital signs prior to, during, and after blood transfusion administration. If we only have one set of vitals, we have no comparison. We have no way to track our patient and catch anything that might be going south. We need to understand the facility protocols concerning blood transfusions. We need to always, always, always stop the transfusion at the first sign of transfusion reaction. And we need to document that transfusion reaction and notify the physician. So baseline data collection that must take place before administering blood. We must know the patient's renal and cardiac function, their lung sounds, and their vitals. We have to have a baseline, or we have nothing, just like with any assessment. If we don't have a baseline, we don't have a comparison, and we don't know when a status change occurs. We need to know, have they ever had a blood transfusion? We need to know if they have ever had a reaction, if they have had a transfusion. And if they have a history of transfusion reactions, we must let the physician know prior to. Mistakes in blood transfusion can be fatal. After obtaining the blood from the blood bank, 2 nurses will perform the following task at the patient's bedside. This is not a task in which you can be distracted in doing. You never should be in regards to administering medications or blood or anything like that. Your patient needs to identify themselves, name and date of birth. They need to have an ID band on that you can compare. And then most places they'll have a separate blood band that says their blood type, and their information will be on there as well. And you will compare it. You will get a piece of paper from the lab, and you will get your blood from the lab, and you must compare all 3. You need to look at their ABO type, their RH type, and that the unit numbers all match. And then we also need to check the expiration date on the bag of blood. A blood warmer is a machine that warms the cold blood from the blood bank prior to administration and brings it to body temperature. And that warming helps prevent hypothermia, which can cause heart dysrhythmias and destroy those blood cells. So in regards to giving blood, you are going to, blood needs to be completed within 4 hours. The whole bag needs to be gone within a 4-hour period. And then, different facilities have different policies, but you usually start it kind of slow, make sure your patient's doing well, and then increase it. But in increasing it, you just have to make sure that your patient is going to get all of that blood over that 4-hour period. We've already talked about, veins and arteries and all of that stuff. So when we're giving blood, we need to make sure that we have a 20 gauge in our vein, in our patient's vein. We need to make sure that it can sustain the blood that we are administering. And then we're going to have, I don't want to talk about the difference between veins and arteries right now either. When we are starting our IV for blood administration, we are starting in the vein. We don't start IVs in arteries, okay? Arteries have pulsation, they have pulses, they don't have any valves, they flow away from the heart. So we're inserting our IV catheters into veins, not arteries. And so asepsis, as always, is incredibly important. Just being diligent and making sure that when you get these orders for blood, that you know your role and your patient's safety is of the utmost priority and that they're educated. You also have to make sure that you have a blood consent on the chart. They're usually only good for 48 hours, but that may also vary from facility to facility. You can email me with any questions, but that is it on your blood transfusion lecture.